Good morning, students. So today we will be reading about acute gingival infections. Okay. So when we say acute gingival infections, so we are aware of the fact that it is going to be a sudden onset, short duration, and it is going to be painful lesion. And yes, it is going to have some systemic manifestations like elevated temperature, okay, and lymphadenopathies. Okay, and increased pulse rate. Okay, these kind of manifestations will be there. Okay, so when we see the acute lesions, we can divide it into 3 lesions basically. Okay, so the first one is the acute necrotizing ulcerative gingivitis. Okay, the second one is the primary herpetic gingival stomatitis, and the third one is the pericoronitis. We have other lesions which are of acute in nature, like your abscesses, which could be of a periapical, okay, periapical, periodontal, or lateral abscess, and we also have the pericoronal abscess, which could also be acute in nature. Okay, now when we see the necrotizing ulcerative gingivitis, it can also involve, or it can also extend into the underlying periodontal structures and form necrotizing ulcerative periodontitis. Okay, it involves the underlying periodontal structures, and it is going to cause the destruction of the underlying periodontal structures, leading to bone loss and connective tissue loss. Then it is called as acute necrotizing ulcerative periodontitis. Okay, so today we will be dealing it one by one in detail. Okay, now the first one is acute necrotizing ulcerative gingivitis. Okay, so as the term indicates, this is again going to be acute in nature. Okay, necrotizing, which means some necrotic areas, presence of some necrotic areas. Okay, and ulcerative, which means it shows its clinical presentations with ulcers. Okay, gingivitis, which is the inflammation of the gingiva. Okay, so when we talk about acute necrotizing ulcerative gingivitis, when we see the causative factor, why it is going to be caused. Okay, so this is basically caused because of the microbial complexes, which is the bacterial in origin, which mostly involves fusospirochetal complexes. Okay, so this has its characteristic bacterial origin of fusospirochetal, which could be of fusobacterium and spirochetes like Treponema pallidum, Treponema denticulum. Okay. Okay, and along with the bacterial origin, it also has some host factors involved in it. Okay, it is not only the bacterial origin, but also it has its host factors, which is responsible for the aggravation of the disease. Okay, so we have some other names of the acute necrotizing ulcerative gingivitis. So it is also called as ulceromembranous gingivitis because of the formation of pseudomembranous slough. Okay, it is also called as Vincent's gingivitis. This came after the histological significance of the French physician Vincent, who gave a deep understanding of this condition. And next, it is also called as necrotizing gingivostomatitis because it is going to involve the underlying alveolar bone. Okay, and it is also called as trench mouth. Okay, so this has been called as trench mouth because it has been more prevalent in the soldiers during the World War I. Okay, soldiers in World War I. So what happens is, during the World War I in the battlefield trenches, because of the intense psychological stress and poor oral hygiene habits, these soldiers developed a painful gum condition called as anug or trench mouth. Okay, so this trench mouth has been derived after this concept. Okay, so these are some of the other names of acute necrotizing ulcerative gingivitis. Okay, now when we see the epidemiology and the prevalence of acute necrotizing ulcerative gingivitis, this is going to occur in groups. Okay, this is not going to affect a single person. This is just going to affect in group. It occurs persons at all the ages, particularly between 15 to 20 years and 20 to 30 years, okay? And this is going to be more common in the children who are under low socioeconomic groups, okay, with the underdeveloped countries, most common in the underdeveloped countries, okay? And it is going to be more common in children with the Down syndromes because of the impaired host response. Impaired host response. So these kids are more prone for the development of acute necrotizing ulcerative gingival lesions, okay? Next. So when we just read about the etiology of acute necrotizing ulcerative gingivitis, as I have already discussed, this is of a mixed bacterial and host response factors, okay? This has mixed bacterial and host response factors. So when we see the role of bacteria in acute necrotizing ulcerative gingivitis, as I have already said, this is more of a mixed bacterial, mixed fusospirochetal origin, okay, along with some other bacteria like P. gingivalis, P. intermedia in some of the cases, okay. So next, when we see the host response, this is not going to occur in all the individuals, okay. So we can see mostly in patients with a reduced immunological response, particularly in immunocompromised status such as HIV, AIDS individuals, okay. Because of the reduced immunological response, they are more prone for developing lesions such as acute necrotizing ulcerative gingivitis and even ANUP and linear gingival erythema, okay. So when we see the other predisposing factors, so there are some other predisposing factors which are important for the development of these kind of lesions, okay. They are the nutritional deficiency, psychosomatic factors and debilitating diseases. So when we see the nutritional deficiencies, particularly in children with the malnutrition, okay, in children with the malnutritions, children with the protein deficiencies, we can say that because of the reduced nutrition availability to the tissues and cells, this is going to cause more susceptibility. The cells and tissues are more susceptible to any of the infections, okay. So in case of malnutrition, there is going to be reduced nutrition availability to the cells and tissues, thereby causing them more susceptible or prone for infections, okay. So when we say something called as psychosomatic factors, this basically tries to say about the factors like stress, because what happens is in stress there is going to be an increase in the cortisol level, okay. So this cortisol level, what happens is it increases the cortisone production and causes and makes them more susceptible to infections, okay. It reduces the immunological response and makes them more susceptible to infections, okay. So in individuals with stress, lesions like ANAG are going to be common, okay. Now in patients who are recovered from debilitating disorders like Parkinson's diseases, Alzheimer's diseases, again they are also going to be very susceptible for the lesions like acute necrotizing ulcerative gingivitis, okay. So these are the major etiological factors for the development of acute necrotizing ulcerative gingival lesions, okay. Now when we see the clinical features of NUG, this is very important, okay. So you can see the picture. The most important clinical feature is it has a punched out or a scooped out crater-like depressions at the crest of the interdental papilla, okay. So the papilla is going to be, so when we see the marginal gingivas, so it usually affects the papilla, which is going to have a crest, okay, or a depression or a punched out appearances in this area, okay. Sometimes this involvement of the interdental papilla might extend into the marginal gingiva and also the attached gingiva and alveolar mucosa, okay. So next is, it is going to be covered by a grayish pseudomembranous slough, okay. So this is an again important classic feature of ANAG, so which means the craters are going to be covered by a grayish pseudomembranous slough, okay, which is going to be demarcated from the marginal or the gingival mucosa by a pronounced linear gingival erythema, okay. Next, there is going to be some constant radiating or gnawing pain, which is going to be increased when the patient is having some spicy foods or even during eating also. Okay, and again the patient is going to tell for a metallic fold taste. Okay, so these are some of the important clinical features. Okay, as you can see in the picture here, the patient is presenting with a necrosis. You can see that the tip of the papilla has been necrosed. There is a osseous crater or a depression. Crater, okay, necrotic areas are seen here. And this, if you see this picture, there is some pseudomembranous slough which is covering the slough, grayish white pseudomembranous slough which is covering the tip of the interdental papilla. Okay, now there are some other clinical features like here the lesions are going to be denuded of the entire surfaces. Okay, there is going to be denudation of the entire surfaces, thereby resulting in the red, shiny and hemorrhagic appearance of the gingivas. And yes, there will be spontaneous bleeding. Okay, there is going to be fetid odor. This could be because of the putrefaction of the necrotic areas. Putrefaction of necrotic areas and debris. There is going to be some fetid odor. Okay, and the lesions are going to be extremely sensitive to the touch because it's going to be having a denuded appearances, and there is going to be excessive salivation, which is meaning as pasty saliva. Okay, which is called as pasty saliva, which sometimes the patient might itself be able to appreciate it. Okay, so these are some of the important clinical features of acute necrotizing ulcerative gingivitis. Okay, now when we see the extraoral systemic signs and symptoms, so in most of the cases the patients are going to be ambulatory, okay, with very less milder signs and symptoms, systemic symptoms. Okay, but in case of mild and moderate forms of ANAC, there is going to be some local lymphadenopathies. Okay, and slight elevation in the temperature. Okay, and in case of severe form, there is going to be a high fever, an increased pulse rate, leukocytosis, loss of appetite, and sometimes generalized lassitude also. Okay, so these are some of the other extraoral signs and symptoms. Fine. Okay, now there is some stages which has been given by Pinbog. Okay, so he has described the stages of ANAG depending upon the progression. Okay, so now he has given 4 stages totally, and it is going to involve the tip of the interdental papillae. It is called as stage 1. Okay, so when it is just involving the tip of the papilla, when the ANAG is going to involve just the tip of the papilla, it is called as stage 1. Okay, now what is stage 2? Stage 2 means if this extension of the lesion, if it is going to extend to your marginal gingiva, okay, if it is going to extend to the marginal gingiva, okay, and causes complete loss of papilla, this is called as stage 2. Okay, so this is stage 1 and this is stage 2. Okay, now what is stage 3? Stage 3, if the lesion is going to extend to the attached gingiva. Okay, if it is extending the attached gingiva, it is called as stage 3. Okay, here we can see that it has been almost extending to the attached gingiva here. Okay, so this is called as stage 3. Okay, now what is stage 4? If it is going to involve the underlying bone also, if it is going to expose your bone, it is called as stage 4. So you can see that the bone has also been exposed here. So this is called as stage 4. Okay, so this is the pinbox stages of progression of necrotizing ulcerative gingival lesions. Okay, so we have to remember there are 4 stages. The first stage is if it is going to involve just the tip of the papilla. Second stage, it involves the entire papilla with along the marginal gingiva. And third stage, if it is going to extend into the attached gingiva. And fourth stage, if it is going to cause exposure of the underlying bone. Okay, so these are the 4 stages of progression. Okay, now there is another staging which was been given by Horning and Cohen. Okay, so this is just an extension of the stages which has already been given by Pinbog. So here he has given 7 stages basically. Okay. So now what is the first stage? The first stage, as I've already told, this is just involving the tip of the interdental papilla. Okay, and in stage 2, this is causing the necrosis of the entire papilla, okay. And in stage 3, what happens is it is going to extend into the gingival margin also, okay. Now, in stage 4, it extends to the attached gingiva, okay. Remember, the stage 2 is going to be the stage 1 and stage 2 is going to be localized to the papilla, tip of the papillas and entire papillas. In stage 3, it is going to involve the gingival margin, okay. And in stage 4, it is going to extend to the attached gingiva. Okay, and in stage 5, what happens is the necrosis is going to extend into the alveolar mucosa also, labial or the alveolar mucosas, and also the labial or the buccal mucosas. Okay, so which is called as necrotizing stomatitis. And in stage 6, what happens is the necrosis is going to expose the alveolar bone. Okay, and in here it is going to involve the alveolar bone. Okay, and in stage 7, what happens is the necrosis is again going to perforate the skin of the cheek. Okay, it is called as noma. So when there is going to be a perforation of the skin of the cheek, it is called as noma. Okay, so these are the stages, 7 stages which has been given by Horning and Cohen. So the one which is given in the bracket tells about the prevalence of these lesions. So as you can see, the prevalence is going to be more, around 52% in case of lesions involving the papilla. And as you go down further, the prevalence of this noma is going to be very, very less. Okay, so this just tells about the progression of the necrotizing ulcerative gingival lesions. The NUG basically progresses into NUP, okay, which then again progresses into necrotizing stomatitis and noma. Stomatitis and noma. Okay, so these are the different stages of progression of NUG. Okay, so this is very, very important. I hope you understood this stages. Okay. Okay, so this picture also depicts the stages. Okay, so this shows how it is involving the papilla and how it is going to involve the papilla and the tip of the papilla. So this is a stage of necrotizing ulcerative gingivitis. So this is a stage of necrotizing ulcerative periodontitis if it is involving the underlying periodontal structures leading to bone loss and attachment loss. Bone loss and attachment loss. Okay, and this stage is the stage of exposure of alveolar bone, underlying bone. As you can see, the entire palate has been necrosed. Okay, so this stage is the necrotizing stomatitis. Okay. Okay, and this stage is the stage of noma, where you can stage of noma. As you can see, this is going to almost perforate the entire skin of the cheek. Okay, so these are the different stages of progression of NUG. Okay, now there are some zones. Okay, there are some histopathological zones which has been given by Lisgarten. Okay, so this is very important. So he has described these zones from the superficial to the deepest areas. Okay, so he has started from superficial and he has gone and identified in the deeper zones. Okay, so when you see histopathologically, the first zone which we can appreciate is the zone of bacteria. Okay, so here what we can see is there is going to be spirochetes which could be of small, medium and large type. Okay, the first zone is the bacterial zone and the second zone is the neutrophil rich zone, where you can see some neutrophils in it, like you can see all the leukocytes, PMNs with bacteria interspersed. Okay, now the third zone is going to be a necrotic zone. Okay, so the first is going to be bacterial zone. Later on, it is going to be a zone of neutrophil, and the deeper zone would be of a necrotic zone, where you can see all the dead and degenerated tissues and cells, okay, tissue cells and fibrillar materials, remnants of collagen fibers, and even the spirochetes, okay, dead and debris of the spirochetes, okay. Now, the fourth zone is going to be the zone of spirochetal infiltration. That means as you go farther deeply, there is going to be penetration of the spirochetes, because these spirochetes, as we know, it is going to be motile, they are motile organisms. So what they do is they penetrate deep into the gingival surfaces. They can be seen almost as deep as 300 microns from the surface. Okay, so these are some of the different zones which has been given by Lisgarten in histopathological appearance. Okay, so I hope you understand this. I hope you remember. Maybe you can remember this Lisgarten zones with the mnemonic called as banana. So I usually remember like this. You can remember this by using the mnemonic called as banana. B stands for bacterial zone, N stands for neutrophil zone, and this N stands for the necrotic zone, and last is the bananas. This is the spirochetal zone. Okay. So how are you going to differentiate between both the ends? You can remember like this. It's new neck. Okay. New means neutrophil. The first is the neutrophil zone, and the next is the neck, which is the necrotic zone. Okay. So maybe you can remember like this. Okay. Fine. So when I'm going to see the histopathological view of anug lesion, there is going to be involvement of both epithelium, okay, both epithelium and the underlying connective tissue are going to be involved in the anug lesions, okay. So what happens in the epithelium is that there is going to be, as I've already told, there is going to be necrosis of the epithelium, okay, there is going to be ulcerations of the epithelium, okay. There is going to be necrosis and ulceration of the epitheliums, and when you see the connective tissue, there is going to be multiple hyperemic areas with engorged capillaries and dense infiltration of PMNs. Okay, so from this concept, remember I have told that there is going to be no pocket formation in anug unless if it is involving the formation in anug, unless if it is going to be involving the underlying connective tissue structures. So the reason behind this is because of the necrosis of the junctional epithelium, okay, because a viable junctional epithelium is required for the formation of the pocket. So this is the reason there is going to be no pocket formation. Okay, so now coming back to the histopathology, there is going to be, as I said earlier, there is going to be necrosis and ulcerations of the underlying epithelium, and the connective tissue is going to be hyperemic with numerous engorged capillaries with dense infiltration of inflammatory cells. Okay, now there is going to be an acutely inflamed zone which is seen, which appears clinically as a linear erythema, okay, beneath the pseudomembranous layer. Fine. Okay, so this is a spirochetal infiltration. As you can see, the rod shaped spirochetes in the bacterial smear from a lesion in anug. Okay. Okay, so when we talk about the communicability or the natural spread of infection, so a question arises whether the nug is going to be communicable or if it is going to spread from person to person. So if we ask this is going to be a non-communicable. Anug is going to be a non-communicable, unlike the other viral infections. Okay, so this is not a communicable or not contagious. Both are similar. It's not communicable, not contagious. Okay, so it just occurs in an epidemic-like outbreaks. Okay, it is not going to be contagious, but it just occurs in a people with the common predisposing factors. Okay, in the affected groups, like common predisposing factors, like patients, children with living in reduced or low socioeconomic groups, or children with socioeconomic groups, and children with malnutrition. So these kind of children, they have an epidemic outbreak, but it is not that it is going to be spreading from person to person. Okay. Okay. Now, when we see the treatment of anug, we can understand the treatment of anug from this point, because it is going to be very, very important from a periodontal perspective. Okay, so this treatment of anug is a very, very important thing which you have to remember. Okay, so there are 3 to 4 visits which are required for the management of anug patients. So when a patient is coming, what do we have to do in the first visit? So in the first visit, what we have to do is, first we have to evaluate the complete history. Okay, so we have to ask the complete history. Okay, a complete medical history has to be taken. Okay, family history has to be taken. Diet history and habit history has to be taken. Okay, if there is any smoking habits or any other abuse habits, so all the history part has to be taken carefully. Okay, and the next one which we have to do is, we have to apply the topical anesthetic sprays. Okay, and we have to gently swab the area with a moist cotton pellet. Okay, we have to take a moist cotton pellet and we have to try to remove the pseudomembranous slough. Okay, the pseudomembranous slough has to be removed, and once you remove it, there might be some underlying debris which also has to be removed. Okay, so followed by the superficial scaling. Okay, a supragingival scaling has to be done. Okay, since there is going to be a annoying pain for the patient, you just want to do a supragingival scaling to reduce the inflammatory components. Okay, inflammatory components. And next, if there is any systemic involvement like fever or lymph node enlargements, so in these cases you have to prescribe antibiotics also. Okay, the preferred antibiotic for this another condition is amoxicillin, which is going to act for all your gram-positive organisms, and metronidazole for your anaerobic organisms, because as we know, fusospirochete is going to be a anaerobic infection. Okay, now again, what we have to advise the patients, what are the oral hygiene instructions which we have to give to the patient is, we have to advise the patient to rinse with a 3% of hydrogen peroxide, which is mixed with the warm water. Okay, an equal mixture of 3% of hydrogen peroxide has to be mixed with the warm water, and it has to be rinsed at least every 2 hours. Okay, it has to be rinsed at least every 2 hours. Also it can be, and or also it can be combined with our normal routine 0.12% of chlorhexidine solution, again which has to be used for twice daily. Okay, now one thing which you have to remember in the management of unlike patients is, which you have to delay all your other invasive procedures like extractions. Okay, because this again is going to be a unlike patients, they are more susceptible to infections, and hence these kind of invasive procedures has to be delayed for at least 4 weeks. Okay, now what we have to do it in the second visit. So the patient is coming 1 to 2 days after the first visit. So again here we are going to do a supragingival scaling. Okay, superficial scaling, and we can continue the same treatment, whatever we did in the first treatment. Like we have to remove the pseudomembranous slough with a moist cotton pellet slough. Okay, with cotton pellet, moist cotton pellets, and we have to advise the patients with the oral hygiene instructions has to be given for usage of hydrogen peroxide mouthwashes and chlorhexidine mouthwashes. Okay, now what we have to do in the third visit. So in the third visit, which comes which we can recall the patient after 5 days, where now we are doing a subgingival scaling. Okay, so in the third visit we are doing a subgingival scaling. So what happens is, because of the supragingival scaling which we have done in the earlier visits, the inflammation is now going to reduce, and it is going to expose all your subgingival deposits. So now you can remove all the subgingival calculus, and root planing has to be done in this visit. Okay. Okay, so now you can ask the patient to discontinue the hydrogen peroxide mouthwashes, rinses, and you can ask the patient to continue with the chlorhexidine rinses for at least 2 to 3 weeks. Okay, now we can give all the biofilm control procedures, and again the most important thing which we have to do, right from the first visit itself, is to counsel the patient on the nutrition. Okay, depend on the smoking cessation. We have to tell the patient that the patient has to quit the smoking if there is any habit of smoking, and also if there is any other habits which is associated with a potential recurrence. Okay, and then we have to recall the patient for any of the corrective treatment, which means, as we have already told, that there is some crater formations, right? There is osseous craters or gingival craters which is formed in the neck patients. So these craters has to be, reshaped by using either a minor surgical procedure such as gingivoplasty or gingivectomies, in order to bring back the ideal contour of the gingiva, so that the patient can maintain in a better way. Okay, so these things has to be done during the third visit. Fine. Okay, so next the second acute infection is the primary herpetic gingivostomatitis. Okay, as the name indicates, this is going to be a primary lesion. Okay, That is the first lesion which is going to occur. And herpetic, which means which is caused by the herpes virus, okay, and gingival stomatitis, which is going to involve your gingiva and the underlying oral mucosas. Okay, so as I told earlier, it is going to be caused by the herpes simplex type 1 virus. Okay, it is most commonly seen in the infants and children younger than 6 years, which means they are more common in the preschool children. Okay. So these primary herpetic gingival stomatitis are going to be more common in the preschool children, and the male is to female ratio is going to be 1:1. Okay, the infection, the primary infection is going to be mostly asymptomatic. Okay, so initially it doesn't show any of the symptoms, but if the primary infection, so sometimes what happens is the virus might ascend through your sensory and autonomic nerves. Okay, it ascends through the sensory and the autonomic nerves, which later, okay, which ascends through the sensory and autonomic nerves and later persists in the ganglions. Okay, so initially it is going to be primary infection, okay, where it is going to be asymptomatic. Now what happens is the virus is going to be latent virus, the virus is going to be latent. So now what happens is in the later period of life, this virus transcends or travels through the sensory and autonomic nervous system, where it is going to remain in the ganglia, neuronal ganglia. And whenever there is going to be a stimulus or a secondary stimulus happening in the later period of life, this is going to show some secondary manifestations. Okay. So this is the clinical course of herpes virus lesions. Okay, so as I told earlier, this is going to be there is going to be some secondary manifestations in the later period of life when it is going to be stimulated with the various stimulus such as light, trauma, fever, and stress. And even you can, whenever we give any of the dental procedures, even when we give LA, that again is going to act as a stimuli and it is going to induce the herpes lesions. Okay, so there is going to be herpes labialis, which are the herpes lesions in the lips of the patient, and herpetic stomatitis. Okay, so this picture shows how the child is developing lesions, ulcerative lesions with the herpetic vesicles in the corners of the mouth. Okay. Now, when we see the clinical features of primary herpetic gingival stomatitis, there is going to be a classic, vesiculobullous lesions. Okay, vesiculobullous lesions. Okay, and there is going to be a formation of multiple ulcers due to the rupture of the vesicles. Okay, so initially there is going to be diffuse involvement of the attached gingivas. There is going to be a diffuse involvement of the gingiva and the alveolar mucosa. Okay, later on there is going to be formation of vesiculobullous lesions. These vesiculobullous lesions, they rupture and forms multiple ulcers in the lips and the entire oral mucosa. Okay, so there is going to be a diffuse erythematous shiny involvement of the gingiva and the adjacent oral mucosas. There is going to be various degrees of edema and gingival bleeding. So the initial stage, it presents clinically by discrete spherical gray vesicle formations, and after 24 hours what happens is the vesicle is going to rupture. Okay, so after 24 hours, what happens is the vesicle is going to rupture, and which will lead to formation of painful small ulcers with a red elevated halo-like margins. Okay, so these are the red elevated halo-like margins, which has a central portion of central whitish or yellow pseudomembranous layer, which is going to be surrounded by an erythematous halo. Okay, halo-like margin. Okay, so now these vesicles are going to either occur separately or they might be in clusters with a confluence. Okay, so the clinical course of the primary herpetic gingival is going to be just for 7 to 10 days. Okay, so that is why we tell these viral lesions to be self-limiting in nature. Okay, so after 7 to 10 days, it is going to regress spontaneously. Okay, so here the scarring is not going to happen. Okay, so remember, the scarring is not going to happen in the primary herpetic gingival. Okay. Okay, so when we see the other oral symptoms, there might be generalized soreness. The patient might tell for the generalized soreness. He might have difficulty in eating and drinking. Okay, the ruptured vesicles might cause focal sites of pain. Okay, it might be sensitive to touch. The patient might have sensitivity to thermal changes and even when he's masticating. Okay, and there are some other systemic involvement like cervical adenitis, high fever, and a generalized malaise. Okay, so this picture shows ulcers, multiple small ulcers, ulcerative lesions in the palate. Okay, small ulcerations in the palate, which again is the cause of primary herpetic gingival. Okay. Okay, now when we understand the histopathological view of primary herpetic gingival, we can say that the virus targets the epithelial cells. Okay, there is going to be ballooning degeneration of the epithelial cells, which is an important classic term given for primary herpetic gingival, degeneration of epithelial cells. Okay, which is called as Zahn cells. Okay, Zahn cells, there is going to be acantholysis, which means there is going to be loss of cohesion in the intercellular spaces, and when this leads to where the infected cells are going to fuse together, they form multinucleated cells, and with intercellular edemas, there is going to be formation of intercellular edemas, and this leads to formation of intraepithelial vesicles. So there are intraepithelial vesicles which are formed, and these vesicles, when they rupture, they form discrete ulcerations with the central portion of acute inflammations of purulent exudates, which is going to be surrounded by a layer of engorged capillaries. Okay, so this is how the lesion is going to progress, and this histopathological view shows the clinical classical feature of primary herpetic gingival with the vesicle formations. Okay. Okay. Now, when we see the diagnosis, now how are you going to diagnose this condition is, you have to always have a careful evaluation of the history. Okay. So you have to take a careful history. Okay, then you have to make all the confirmatory laboratory tests. Okay, you have to go for the cultivation of viruses, and there are some other immunological tests like detection of monoclonal antibodies, and you can also go for the DNA hybridization techniques. Okay, so these are some of the diagnostic tests for the primary herpetic gingival. Okay. Now, there are some differential diagnoses in which some of the other lesions which present with the same clinical presentations like erythema multiforme, Steve Johnson syndrome, bullous lichen planus, desquamative gingivitis, and lesions of recurrent after stomatitis. Okay, so these are some of the other conditions which shows a same presentation, clinical presentation like primary herpetic gingival. So you have to always narrow down with your history. You have to be able to rule out the diagnosis of the condition. Okay. Okay. So when we see the communicability of primary herpetic gingival, it is going to be contagious. That means it is going to spread from person to person through any of the airborne route, okay, or by a vector, orthoprod vectors, or by direct contact, sharing of utensils, or sharing of utensils, or even by drinking and eating with drinking water and sharing the food. Okay, so although this is going to be contagious, there is some subclinical infection during childhood due to primary herpetic lesions, which is going to give immunity to the herpes simplex virus lesions. Okay. Okay, so this table I've just summarized the difference between UNUG and primary herpetic gingivitis. As we have studied, the causative factor of UNUG is going to be the bacteria. Okay, there is going to be interaction between the bacterias, most probably the bacteria and the host, and here it is going to be a viral etiology. Okay, and when we see the how it presents clinically, this is going to be a necrotizing condition. It has punched out gingival margins. There is going to be a pseudomembranous slough. When it is going to be peeled off, it leaves a raw erythematous areas. And when you see this clinical presentation, it is going to be more of a vesicular eruptions, okay, and there is going to be some slightly depressed oval or spherical ulcerations. Okay, now when we see where the condition exactly presents is, here the marginal gingiva is going to be affected. Okay, and the other oral tissues are going to be rarely affected. Okay, it usually affects the interdental papilla and the marginal gingiva. Whereas when we see the primary herpetic gingivitis, there is going to be a diffuse involvement of the gingiva, including the buccal mucosas, lips. Sometimes it involves the palate also. Okay, the ulcerative lesions involves the palate also. Now this is going to be uncommon in the children. This is going to be more common in the young adolescents. Okay, this is going to be more common in the young adolescents. Okay, there is no definite duration for this diseases. Okay, here this is going to be more frequently seen in the children, mostly in the preschool children. Okay, less than 6 years. Okay, now there is going to be no definite duration for this diseases, whereas for the primary herpetic gingivitis, there is going to be a duration of 7 to 10 days, which is going to self-limit. Okay. So one important thing which I have to add on here is, so if the lesion or the clinical course of the disease is between 3 to 4 days, you can treat this condition by giving acyclovir. Okay, you can administer acyclovir. But yes, if the clinical course of the disease is between 5 to 7 days, your acyclovir or any other antiviral drugs are not going to help, because by this time the virus might have reached the might have traveled through the nerves and it might have reached the ganglion. Okay, so only if it is going to be between 3 to 4 days, you are giving or prescribing of antiviral drugs are going to be helpful. Okay, now when we see the contagiousness, this is not going to be transmitted from person to person, whereas this is going to be contagious. Okay, so these are some of the major differences between UNUG and acute necrotizing ulcerative gingivitis and primary herpetic gingivitis. Okay. Okay, now the third acute gingival infection is the pericoronitis. Okay, as the term indicates, pericoronitis is the inflammation of the gingiva surrounding the crown of an incompletely erupted tooth. Okay, so this picture shows that. So this picture is showing the pericoronitis, where we can see that the inflamed operculum is covering the partially erupted molar. Okay, so this is going to be most common in the mandibular third molar areas. Okay, and that is why this is going to be a very important lesion, because this might involve the, if the lesion is not treated, this might involve the underlying anatomical spaces. Okay, and it can lead to potential sequelae like Ludwig's angina, where it is going to be involvement of all the three spaces like sublingual, submental and submandibular spaces. Okay, there might be formation of peritonsillar abscess. Okay, there is going to be involvement of retropharyngeal areas. Okay, and that is why this is going to be a very important life-threatening condition. Okay, this has to be treated as soon as possible. Now, so what happens is, the space between the crown and the operculum. Okay, so what happens is, this is the inflamed operculum. Okay, so this is a flap which is covering the incompletely erupted tooth, okay, what happens is there is going to be a continuous food lodgement. Because of the continuous food lodgement between the loose flap and the incompletely erupted tooth, there is going to be bacterial proliferation. There is going to be bacterial proliferation, and what happens? Now there is going to be deepening of pocket here. Okay, so this area there is going to be a deepened pocket, deepening of pocket. Okay, there is a deepened pocket because of the continuous food lodgement. This area is going to be very loose, and because of that there is going to be a bacterial proliferation and deepening of the pocket, and because of that this area inflames and swells up. Okay, this inflames and swells up, and the patient is going to have clinical presentation with pain, okay, severe pain, trismus, which is the difficulty in opening the mouth, okay, swelling. Pain is basically of a gnawing, radiating pain. Sometimes it might radiate to the ear also. Okay, so this is all the clinical presentations. Okay, sometimes it might be occupied with the tonsillitis, fever. So some other systemic involvement might also be there. Okay. Okay, so when we see the clinical features, as I've told earlier, the space between the crown and the operculum, the space between the crown and the operculum is going to be accumulated with the food particles and the debris, okay, leading to the bacterial growth. So here there is going to be a acute inflammatory involvement if it is going to be exacerbated by trauma. So what happens is, whenever there is a incompletely erupted tooth, so this is going to be covered by the operculum, there might be a supra-erupted upper molar which is constantly creating trauma, or if it is impinging, constantly impinging the operculum, okay, impinging the flap, leading to pain and inflammation. Okay, so this might also be exacerbated by occlusion or a foreign body which has been trapped beneath the flap. Okay, so there is going to be some inflammatory fluid and cellular exudative process which is happening, which increases the bulk of the flap, leading to interference with the complete closure of the jaws. Okay, so these are some of the clinical features of pericoronitis. Now, as I've told earlier, the flap is going to be red, swollen, and it's going to be a suppurative lesion with radiating pain to the ear, okay, throat, and the floor of the mouth. There is going to be a foul taste, and there is going to be inability to close the jaws. There is going to be swelling of the cheek in the region of the angle of the mouth. It is going to be also associated with the lymphadenitis, trismus, difficulty in opening the mouth. Okay. And there is going to be fever, leukocytosis, and malaise. Okay. Okay, so there is some complications which I've already discussed. There are some chances of pericoronal abscess formations when this inflammation is going to spread inside the oropharyngeal areas, and sometimes it might spread measly to the base of the tongue also. There is going to be involvement of the submaxillary, posterior cervical, deep cervical, and all other lymph nodes also, and even the retropharyngeal lymph nodes. Okay, there is going to be peritonsillar abscess formations, cellulitis, and Ludwig's angina, which are the potential sequelae of an untreated third molar, okay, inflammation. Now, coming to the treatment of pericoronitis. So, this treatment part basically depends upon the position and the location of the tooth. Position of the tooth, okay. So, depending upon the position or the location of the teeth, the treatment can be either extraction, okay, or periodontal intervention. So these treatment purely depends upon the position and the location of the teeth. Okay, so now the initial treatment of pericoronitis, what we have to do is we have to gently flush the area with a warm water to remove the debris and exudates. You can even do a subgingival scaling. You can put a topical spray and you can do a subgingival scaling to remove all the debris and the exudates. Okay, and what you have to do is the occlusion has to be evaluated. Okay, you have to check the occlusion if there is any hindrance from the or impingement from the opposing tooth. Okay, so what you have to do is you have to shape this area. Okay, you have to do coronoplasties and you have to shape this area so that there is no continuous recurrent trauma to the underlying flap. Okay, and if required, so this reduces the recurrent trauma which is happening to the flap. Okay, and if required, we have to reduce the soft tissue surgically. Okay, we have to reduce the soft tissue surgically by doing operculectomy. So what we do is we usually give antibiotics for the patients, okay, and then after 5 days of antibiotic therapies, what we do is we do something called as operculectomies. Okay, we try to excise the operculum so that this might reduce the inflammation, it will reduce the food lodgement, okay, and sometimes it will facilitate the complete eruption of the tooth. Okay. So this might facilitate the complete eruption of the teeth in some cases. Okay. So on the last option would be to go for extraction of the position of the teeth in such a way. Okay. Okay. So thank you, students. This is all about the primary acute gingival infections. Okay. So the most important questions which can be asked is, you can be asked either as an essay question to describe all the acute gingival infections. Okay. So this is again going to be rare for essay, but in case of short notes, you might be asked with ANAG, okay, and its treatment, okay, where you have to explain all the 3 visits. Okay, you have to explain all the 3 visits, first, second, and the third visits. Okay, and separately they can ask about primary herpetic gingivostomatitis. And they can ask about pericoronitis. Okay. So this is all about the acute gingival infections. I hope you understood the topic. Thank you so much. All the very best. Okay.